معكم حلا ياسين، وإن شاء الله رح نناقش موضوع ال gestational diabetes. So a 36-year-old G4 para2 presents to your office for a routine prenatal visit at 24 weeks gestation. Her weight is 99.7 kilograms. Pre-pregnancy weight was 89 kilograms. BMI is 35.7, so she's obese. And her blood pressure is 130/80. Uterine size is appropriate for gestational age, and fetal well-being is reassuring. You recommend testing for gestational diabetes mellitus. Since she's at her 24 weeks, we start screening for GDM at this age. The patient's past obstetric history. The first son was born at the 40 weeks gestation, 4 kilograms, normal vaginal delivery. She had a miscarriage at the 10 weeks gestation. She had twins, 2 girls at the 37 weeks gestation. البيرث weight 2.5 and 2.6 kilograms, a normal vaginal delivery. She is married for 11 years. All her previous pregnancies were unassisted. Her family history reveals that her mother has type 2 diabetes. She has no recurrent UTIs or candida infections, no polydipsia, polyphagia, or polyuria, no personal or family history of GDM. Early screening for GDM was negative. So questions, what are the risk factors for GDM in this patient? I've highlighted the risk factors in red. First, her age, 36-year-old, is a risk factor. Anything above the 35 is a risk factor for GDM. Her weight, obesity is a risk factor. Also, she had a miscarriage, so it could be like a stillbirth. This is a risk factor for GDM, especially at the first trimester. Twins or multi-pregnancy is a risk factor, and her mother has type 2 diabetes. So all of them are risk factors for GDM. That's why in high-risk women, we do early screening for GDM at the first prenatal visits. That's why her screening was negative, the early screening. The second screening is done at the 24 to 28 weeks gestation. So question 2, should everyone be screened for GDM? If so, at what gestational age should they be screened? بالنسبة للسكرين دكتور
ممكن ترجع للسكند سلايد أو الكويستشن السكند سلايد. No, the one before. You highlighted the risk factors. Okay. Now, this is an excellent way of presenting things. It's just I have to clarify something. Of course, any pregnant patient, because of the changes that happen during pregnancy, the physiological changes, but the patient, pregnancy is a diabetogenic status. So any pregnant woman, in theory, is potentially liable to develop gestational diabetes. Now, there are certain risk factors which increase this chance. One of them is the old age. High parity also as a risk factor. Obesity, twins, and the family history. Now, with regard to the miscarriage, now at the 10 weeks, now that cannot be stillbirth. Stillbirth means death of the fetus after the age of viability. So after 24 weeks to call it stillbirth. Now this is a miscarriage, spontaneous miscarriage, one sporadic miscarriage is not a risk factor for diabetes. If you have patients who have recurrent episodes on what we call the recurrent miscarriage, in that case, you might suspect that there might be underlying diabetes. And even though subclinical diabetes doesn't predispose to recurrent miscarriage, it is the poorly controlled diabetes which predispose to recurrent miscarriage. So I just want to make sure that you understand this. Now, we have subclinical diabetes, which is not diagnosed. This is unlikely to cause a recurrent miscarriage, extremely unlikely. Now, if you have a patient who is already diabetic and she is poorly controlled, now this is a risk factor for recurrent miscarriage. Okay?
تمام دكتور.
تمام دكتور.
You carry.
Okay, so screening. Screening for GDM is done in all pregnant women. All pregnant women, whether they have risk factors or not, should be screened for GDM. The timing of screening is at the 24 to 28 weeks of gestation, when the diabetogenic stress of the pregnancy is present. For women at high risk of developing GDM, early screening for GDM is recommended, like our patients, at the first prenatal visit. If the early screen is negative, it should be repeated at 24 to 20 weeks gestation.
Just for a minute in this slide. Now, this is absolutely true, what's being mentioned. Patients who are having risk factors, personal or past obstetric risk factors or family history, they should have an early screen at the booking visit. And even if that's negative, it has to be repeated at 24 weeks and 24 to 28 weeks. But women without risk factors should be screened at 24 and 28 weeks, where this is the status of diabetogenic stress will become maximum. Now, why we don't screen all women at pregnant women at the early gestational age? The reason for that is the chances of picking gestational diabetes is very low and early booking. Now, as the pregnancy advances, the diabetogenic status become more obvious, and therefore, if you do the screen at 24 to 28 weeks, you will pick up more cases than if you do it at the booking. Now, if you do it at 36 weeks, you will pick up even more cases of gestational diabetes. But if you pick it up at 36 weeks, you don't have any time to change the outcome. So the 24, 28 weeks is used because you will pick up the majority of the cases, and at the same time, you have enough time, like from 24 to 40 weeks, you have like 16 weeks where you can change the outcome if you control it and treat it. So this is why 24, 28 weeks has been chosen. You will have the diabetogenic status has already been established. You will pick up a good proportion of the patient who will develop gestational diabetes. And at the same time, you will have enough time to interfere and improve the outcome. Okay?
تمام دكتور.
Carry on.
So how do we diagnose or screen for GDM? The usual approach to screening would be a 50-gram oral glucose load administered to the patient between 24 and 28, like we said, when the diabetic stress is present. A positive test is a venous plasma glucose value for 1 hour later of more than or equals 140 milligrams per deciliter. So at first we do we call a glucose challenge test. This test is done by it's a non-fasting test, so the patient doesn't have to be fasting to do it. We give 50 grams of oral glucose, and then 1 hour later we measure her blood glucose. If it was more than 140, this is a positive test, and we carry on to do the glucose tolerance test. If it's less than 140, this is a negative test, and we don't do the glucose tolerance test. In the glucose tolerance test, the patient should be fasting. At first, we measure her fasting blood sugar, and then we give her 1 grams of oral glucose, and we measure it at 1 hour, 2 hours, and 3 hours. Normal values, fasting should be below 95, 1 hour below 180, 2 hours below 155, and 3 hours below 140. If it's higher than these values, then she has GDM. If one value is abnormal, we call this شو نسيتها شو كان اسمها اللي هي إنه يعني prone to diabetes but not diabetes. GDM should be more than 2. Yes.
Call it impaired glucose
Impaired,
tolerance.
yes. So بالنسبة للpatient, her 1 hour 50 grams is 182 milligrams per deciliter. Does she have GDM? Like we said, to diagnose GDM, we need to do the glucose tolerance test. This is the definite diagnostic test. So we don't stop at the glucose challenge test if it's abnormal. So here her value is 182. It's more than 140. So it's a positive test. So we should do the glucose tolerance test. We did the glucose tolerance test, or the 4 values of her 3-hour glucose tolerance test are elevated, and her fasting glucose level is 127. So it's more than 95. How would you manage her GDM? So now we confirmed that she has gestational diabetes. Now we'll go on to the management. The goal of antepartum treatment. Doctor.
Is there any alternative way of doing this instead of doing these 2 steps, the 50 gram followed by the 100?
I think if the random test is more than 200 with fasting blood glucose is more than 95, then she has GDM. We don't need to do the 3-hour test, glucose tolerance test.
Let me just clarify one thing. Random blood sugar, fasting blood sugar are not a good tests for screening alone. So you don't depend on the fasting, you don't depend on the random for testing. The screening tests which are recommended are either the 2 steps اللي انت عملتيهم حكيتي عنهم. You do by, you start with the 50 gram, and if this is abnormal, then you go to the 100 gram. The alternative way is to do 1 spot testing اللي هو the 75 grams as 170. I mean, this is the American way of doing 2 steps, 50 and 100. The British way, they are more likely to go into a single test of 75 gram glucose load. And if it's more than 140, the 2 hours, more than 140, 2 hours, this is a gestational diabetes. But you don't rely on the fasting, and you don't rely on the random blood sugar, because these are abnormal during pregnancy. Yani the fasting level, what happened during pregnancy is you have the glucose level is increasing, and that will induce an increase in the insulin level. So the basal level of insulin secretion in the pregnant woman will be high. Now, that will result in the fasting blood sugar being lower than non-pregnant level. However, the postprandial, the 2 hours postprandial in the pregnant patient is normally higher than in non-pregnant. So fasting is lower, postprandial is higher than the non-pregnant. And therefore the values you cannot use the values for non-pregnant patient to decide whether this patient is having gestational diabetes or not. And this is why you have to go for the challenge test. Is that clear?
واضح دكتور.
So management of GDM. The goal of antepartum treatment of GDM is to prevent the fetal macrosomia and its resultant complications by maintaining the maternal blood glucose at desirable levels throughout gestation, defined as fasting glucose level below 95 and 1 hour post-prenedial level below 140. The initial management is diet therapy, It was proven that 80% of pregnant women with GDM could benefit from diet therapy and lifestyle management alone and could control their blood glucose. So we don't have to start medications right away at the diagnosis. So the initial management is diet therapy, moderate exercise, daily home glucose monitoring, and weekly antepartum visits to monitor glycemic control. If diet alone does not maintain blood glucose at desirable levels, hypoglycemic therapy may be required. If initial fasting glucose levels are more than 95, treatment can be started immediately because you can diet more than fasting, meaning that if she tried the diet therapy alone and her fasting blood glucose or her blood glucose was abnormal, then we should start the medical management. Insulin, which has to be given several times a day by injection, remains the gold standard for medical management of GDM. And second-generation hypoglycemic agents was proved that they don't cross the placenta and are safe in pregnancy. Previously, they didn't give them these medications because they thought they could cross the placenta and cause hypoglycemia in the infants. But they don't cross the placenta and are safe in pregnancy and can achieve adequate glycemic control in 85% of pregnancies complicated by GDM. The estimated fetal weight. هلا بالنسبة للبيشنت
خلينا بس أعلق على الموضوع بالنسبة ل conservative management without medication for diabetes. Usually diet, exercise and modifications, they will achieve a good control in the pre-diabetic state. Yeah, usually they are beneficial in patients with impaired glucose tolerance. However, once the patient develops true gestational diabetes and she is diagnosed to have gestational diabetes, then diet and exercise alone are unlikely to maintain a good glycemic control, because with what happened with advancing pregnancy, the diabetogenic status will even get even worse. And as you just mentioned, that you cannot fast more than this. You cannot diet more than the fasting. And therefore, eventually, patients will require medical therapy. And therefore, the newest recommendation is that once you diagnose a true gestational diabetes, you start medical therapy. Okay, so lifestyle, dieting, exercise are good for impaired GTT, glucose tolerance. However, once you diagnose gestational diabetes, you continue with these measures, but you will eventually require medical therapy. As regard to the oral hypoglycemic agent, yes, the new generation oral hypoglycemic, you can use it. Metformin, which is the drug commonly used, also can be used safely in pregnancy. We use it quite commonly for patients with polycystic ovarian disease and who got pregnant, and therefore we have enough safety data about metformin. So metformin can be an initial therapy, and if that didn't work, then eventually you will need insulin. Now, insulin will give you a better control than the oral hypoglycemic agent. So if you are aiming at a tight glucose control, then eventually you will need insulin at some point.
Okay. هلا بالنسبة للpatient, she visited at the 38 weeks gestation, and the fetal weight was 4.6 kilogram. So this is a microsomic baby. How would you counsel her about delivery? هلا in general, in patients who have GDM, we recommend delaying the delivery after the 38 weeks gestation, is because the lung maturity are delayed in GDM. So when we delay delivery, we confirm that the lungs are mature enough to the baby to be born. So in this patient, when we have a microsomic baby, complications for the vaginal delivery will be high. Complications like shoulder dystocia and complications on the mother from vaginal, perianal, and rectal trauma. So we counsel the patient at this time to do elective cesarean section at or after the 39 weeks gestation. As we said, we recommend delaying the delivery. And the postpartum management after the delivery of the baby.
هلا ارجع للسلايد اللي قبلها. Yes, totally agree. This is obviously a macrosomic baby, and that will means that the risk of vaginal delivery will be high both to the mother and to the baby, and especially that this macrosomia will be mainly to the trunk and to the shoulder. So the risks are very high, and any patient with diabetes and the estimated fetal weight more than 4 kilograms, then we would recommend a delivery by cesarean section. Now, the timing of the cesarean section, whether 38 or 39, as you said, the patient, infant of diabetic mother, our fetuses, they will have delayed lung maturity compared to the non-diabetic. But after the 38 weeks, the risk of sudden intrauterine fetal death also increase. And therefore, it is usually recommended to deliver them by after 38 weeks, completed weeks. So once they are 38 weeks, you deliver them by a cesarean section. Now, okay, some of them, they will develop respiratory distress, but usually this is a mild form. This should be balanced against the risk of sudden intrauterine fetal death. So the recommendation is to deliver the babies by 38 weeks. by an elective cesarean section.
دكتور قرأت كمان إنه إذا كانت الأم uncontrolled during her pregnancy uncontrolled diabetes, then we should deliver her at the 38, and if she is controlled, we could delay it after or at the 40 weeks. هذا صحيح؟
اللي بتحكيه صحيح، بس المشكلة إنه في sudden intrauterine fetal death اللي هو exponentially increase after 38 weeks. Nobody understanding why this intrauterine fetal death happens. Of course, the more the uncontrolled the diabetes, the higher the risk, but still it does happen in patients with well control of diabetes. So you don't want to risk delaying this and taking the risk of unexplained intrauterine fetal death after 38 weeks, especially you don't have any reliable method of monitoring the baby during this period. Yani CTG, ultrasound, Dopplers are not effective in predicting the risk of intrauterine fetal death. You will see patient, she's completely normal, baby is fine. Today, the next morning, it's dead. So whether controlled or uncontrolled, you deliver it at 38 weeks.
So postpartum management for a female with GDM, a 2-hour non-pregnant glucose tolerance test should be performed at 6 to 8 weeks postpartum in all women with GDM to exclude pre-gestational diabetes. So to confirm that it was GDM, not a clinical diabetes or a pre-gestational diabetes, we redo the glucose tolerance test at the 6 to 8 weeks postpartum.
We have to, because there's less than 1 minute now, we have to go and log in again.
تمام دكتور.
Yes? So
Yes.
let's do it.
Okay.